one moment. Hello and welcome everyone to today's Ask the Expert. I'm so excited to be here with you. I am TMA's Senior Manager of Patient Education Support and Advocacy, and you can see behind me a nice view of Dallas, Texas, which is where we will be having this year's conference, September 18th to the 21st, and I hope that you are able to join us for that. For those of you joining our webinar for the first time, we're broadcasting from Columbia, Maryland, and we'd love to know where you're tuning in from. Everyone, please feel free to share your location in the chat box. It's always wonderful to see how far this community reaches. Make sure that your message is going to everyone and not just the hosts and panelists. You can change who the message is going to by hitting the down arrow and the blue button at the bottom of your chat box. Since 1993, the Myositis Association, otherwise known as TMA, has been dedicated to improving the lives of those affected by myositis, fund innovative research, and increase myositis awareness and advocacy. We envision a world without myositis, and we work tirelessly to get closer to that goal every day by providing education, support, and resources to the myositis community. All right,
I think we lost you. Or is it my internet? Hello? Hello? No, no, we lost Rachel. Oh, is it just me? Can everyone hear me? We lost Rachel. Let's see. Okay. Well, I guess I'll just start introducing myself. I'm here in Baltimore, Maryland. Um, okay, you can hear me? Oh, there she is. Okay. Oh, you're muted. Rachel, you're muted.
I don't know what happened. I was totally kicked out of the webinar. It's the
Oh,
craziest thing that has
that is crazy.
never happened before. One moment. Thank everyone for your patience. There's a couple of things I need to do. I'm not going to play the bumper again. I'll do that in post. But I am going to pause the recording and then start it and again and redo my intro, if y'all do not mind. All right, Julie, can you confirm that you can see my
Yes.
slide?
Yes, I can.
All right, great. Okay, we are going to go fast. Hello and welcome everyone to TMA's Ask the Expert. We are so happy to have you with us today. I'm Rachel Bromley, TMA Senior Manager of Patient Education Support and Advocacy. For those of you joining us for the first time, we're broadcasting from Columbia, Maryland, and we'd love to know where you're tuning in from. So please feel free to share your location in the chat box. It's always wonderful to see how far this community reaches. Since 1993, the Myositis Association has been dedicated to improving the lives of those affected by myositis, fund innovative research, and increase myositis awareness and advocacy. We envision a world without myositis, and we work tirelessly to get closer to that goal every day by providing education, support, and resources to the myositis community. Before we get started, disclaimer, TMA does not give medical advice. Our educational webinars are informational, and we do encourage you to make all decisions about your care in partnership with your healthcare team. TMA is very grateful for our expert speakers from all over the world. We ask each speaker to disclose any potential conflicts at the start of their presentation. This webinar is being recorded and will be available on TMA's YouTube channel on the 1st of next month. Please put any questions you have in the Q&A box. You can find the Q&A box in the toolbar, most likely at the bottom of your screen. Pre-submitted questions are being loaded into Q&A by TMA staff, so you don't need to input them again. I just want to warn you, questions put in the chat box may be missed. TMA evaluates its programming to ensure we are meeting the needs of the myositis community. A survey will pop up at the end of the webinar, and we ask that you please take a few minutes to provide input to inform future programming. Thank you so much. And all right, let me stop sharing, or I can leave it up. It's fine. But I am excited to introduce you to today's expert. Dr. Julie Paik is an associate professor of medicine at Johns Hopkins University School of Medicine. She is the co-director and director of clinical trials at the Johns Hopkins Myositis Center. She also currently serves as vice chair of TMA's Medical Advisory Board. We are so fortunate to have her with us today. Okay, let me stop sharing. That always takes me a minute. I've got two screens here. I used to be a broadcaster, and I so wish that I could make this run like a regular show, but it just isn't set up for that. And so it can get a little awkward, but we do our best, right?
I know, it's great.
Okay, so let me get in. I just want to look in the chat and see who we've got, see who's from where. Got some Pittsburgh, South Florida, Canada. Nice. Oh, someone from Peru. That's nice. Michigan. That's great. All right, let's get to the questions. So far, we have 13 questions, and we're going to go and we'll stop as soon as we get through them. Usually, we can't answer all of them, but I would encourage you to get your questions in as soon as you can, because what seems to happen is right around I get to the close, and then people put in the questions, and I don't have time. Okay, first up, this is someone looking for information on dysphagia. No particular question, just, if you could explain dysphagia, maybe some of the signs and, what people should look for.
Yeah, yeah. So, hello everyone, and I know Shreya introduced me, but I'm just really excited to be here and meet everybody. I wish you could all be like those little videos, but unfortunately it's not. Look forward to meeting everyone one day, maybe at the TMA conference actually in Dallas. But yes, dysphagia, I think, is a difficult topic in a sense that it could be the symptoms can be very difficult. Obviously problem swallowing, but we try to divide it up into, is it more oropharyngeal, meaning like more in the mouth and, swallowing there, or is it more distal? Like, because there is skeletal muscle in the actual swallowing muscles when we try to eat, right? I think 1/3 of the swallowing process, there is some skeletal muscle there. And that's why in myositis, it can be affected there if the skeletal muscle is involved. But we also have problems. There's muscles here in the mouth area, the oropharynx, and that's why that can also cause problems swallowing. But anyways, the main difference for that, is it in the mouth muscles or is it more distal in the tube? The main difference is if you're eating food and if it's more in the mouth muscles, or oropharynx muscles, medical word, then you can actually aspirate, meaning the food can actually go into the lung, and that can be a very big problem because then you can get, infection there, pneumonia there. And I've had patients have that, and it's very difficult. It's very treatable. You get the IV antibiotics or oral antibiotics and things get better. But that is the main concern. If the oral muscles in the mouth are completely disables you from swallowing the food. Versus if it's actually in the tube part where there's muscle there after you swallow the food, then you'll have sensation of like food getting stuck. And you have to chew longer. You can chew, but there's a sensation of food getting stuck. And that's when these other studies can help us figure out those two different kinds. Is it more in the mouth muscles or, in the tube part of the food after you swallowed it? So I don't know if that answered the question, but yeah.
Um, for those of us diagnosed with dermatomyositis, is it safe to get laser hair removal?
Uh, that's an interesting question. I don't know if that patient ever asked me that.
I
Um,
know, but it
yeah,
is something, I
that's
mean,
an
I would want
important
to know
question.
for
Yeah. Yeah,
sure.
yeah, yeah. So, I mean, we always say try to avoid like UV light, but I think laser therapy should be okay. I think I would do like a test spot for hair removal and see because you're not out, like it's not UV exposure, like you're getting UV therapy for like psoriasis or something like this. Like if somebody has psoriasis and dermatomyositis, there's no way we do not recommend any UV therapy. Like for psoriasis, yes, you do, but we know UV therapy for dermatomyositis will completely flare your skin disease. And so laser is not like that. It's focal, it's for hair removal, it's not UVA1. So I think it's fine. But I would test out a spot first. Yeah.
Okay. How much should I push my muscles when exercising? This person also has dermatomyositis, which I don't know if it makes a difference about how much you push depending on the subtype, but you could let us know if it does.
Yeah. We always say don't overexert yourself. You want to work enough that like you're a little bit sore, but not running like a marathon. So it's always gradual buildup. Like if you're doing weights or doing squats, maybe you do instead of doing like 3 or 5 reps, which is like what a normal patient would do with like weights, like 10 pounds or 15 pounds, like you would start with like 3 pounds initially, or 2 pounds, or even just an ankle weight to do squats or, bicep curls or something like this. But you wouldn't go from 0 to 20-pound weights or 10-pound weights. Like it's a gradual incline of weights or exercises. So it's really understanding your own body. And I think that's one thing that I really try to impart to my patients. Like, if before you were not really in tune to your body and how much you can do, it's really important to understand your own body's limits so that you know when you can push a little bit more and not get some type of severe flare or get really weak after. But working with a physical therapist will also guide you because they're looking at your body and your positioning and your posture and how much you can do. So they'll gradually increase what you can do, but never go from 0 to 100, basically.
Is it common for a necrotizing myopathy patient to test positive for anti-SRP 1 year, negative for a couple of years, and then positive again? Would this be referred to as a flare?
That's an interesting question. So the SRP antibody has like 9 different subunits, but there's one that's obviously more commonly positive. That specific subunit that we check on the myositis panel is associated with necrotizing myopathy. But let's say you were treated before with maybe IVIG or rituximab or something like this that does deplete the antibodies, and your titer was not super high, then potentially, maybe that's why it became negative, because your titer was not high from the beginning. But nevertheless, if you have a biopsy that shows necrosis and it is definitively necrotizing myopathy, and you've been treated that way, then I think the clinical presentation is more important than following a titer per se. But I do have to say SRP and HMG-CR antibodies do really track closely with muscle enzymes, muscle strength. And so we do use that in a lot of the clinical trial space to determine if the antibody titers actually correlate with disease activity. So bottom line is, in the research sense, if the titer is suddenly going up really high and tracking with worsening muscle strength and muscle enzymes are also going high, then it could be a sign that maybe the disease is starting to flare. But clinically, we always monitor you on your muscle exam and all this stuff to really understand if that's even clinically meaningful. Because for example, like if the SRP titer was 100 and the cutoff for the assay is 90, like that increase, does that really make a big difference to you in your daily life? I don't know, we really know that answer yet. Hopefully we can get there one day when the antibody titers are uniformly, tested at the same lab everywhere else, so we can compare apples and oranges, because the assay that is done at one hospital is going to be different from another assay. So it's important for your physician to understand where the assay was done, what kind of assay was used to test for SRP or HMCCR, because there's different ways to test it. And is that actually really clinically meaningful is important. Yeah.
Can you explain how you deal with adrenal insufficiency with your patients? How can this be determined, and how do you test for, treat, and get someone off prednisone?
Yeah, that does happen quite a bit. So usually I work in concert with a endocrinologist who specializes, most endocrinologists are very well aware, but they will do testing by doing a stim test, a cortisol stim test. And you have to be on prednisone of 5 milligrams or less usually. And then they will inject, it's a small injection that I think usually the physician does or a nurse practitioner does in the endocrinology office. And then they will see, usually they do it first thing in the morning to see if you have a good rise in the response, a cortisol response, when they stimulate you with ACTH, which is the hormone that stimulates cortisol. And if it's not appropriate, then we would work with the endocrinologist to determine what medication is best to put you on long term. And so that, you can actually avoid having this kind of adrenal insufficiency. And sometimes you may have to be on it for years. But that is something we as rheumatologists don't typically, or neurologists ever really do on our own. But we have to engage the endocrinologist to help us. But it is very treatable, and I've had patients do really well. It just takes a little bit of time. The goal is really, can you get to the 5 milligrams for the endocrinologist to test you for it? Because that is really the gold standard of, giving you the injection and seeing if you have a normal response. Yeah.
A follow-up on that is, what are symptoms of an adrenal problem?
Yes. So no, it's very non-specific, but once you start tapering, those symptoms of feeling really tired, hit by a truck and feeling like exhausted. You may also
Mhm.
feel like muscle aches and joint aches, um, poor appetite, fatigue. And so I think this is where it gets really hard to distinguish, is this really a flare of my disease? Or is this adrenal insufficiency? And sometimes it's even hard for us rheumatologists or your myositis specialists to really know if that, yeah, dizziness can also potentially happen. And the worst case scenario, and I've had this, my patient had to be admitted to the hospital where you get extremely low blood pressure and you pass out, because your body is like in shock mode and it's going to stress response. And so it is important to figure that out, because sometimes, like as I was saying, like I lost train of thought. Sometimes it's hard to distinguish if it's, oh, is this really a myositis flare or not? Because you do get weakness too. In those cases, checking the muscle enzymes will help. Getting a muscle MRI may help. And if those really don't light up, then it's probably not the myositis, but maybe adrenal insufficiency. Yeah.
Okay, this person has hyperextension of both legs, and their specialists aren't sure what to do about it. It's unsafe and painful. Do you have any thoughts?
Oh, you mean does this mean, so there's like benign joint hypermobility disorder? I don't know if that's what, like, so I guess they're saying that the knees are hyperextensible. So when we think about hyperextensible joints, we always worry, is this, benign joint hypermobility disorder where, you can actually hyperextend at the knees or the elbows. and, be able to like, stretch out your fingers more than 9 degrees or something like this. And there's some criteria to diagnose that. But then there's also some patients, because we think about connective tissue disease in a broad spectrum, who actually have Ehlers-Danlos. And so if you have like very hyperextensible skin and things like this, then, you want to have your doctor consider that as well. But if it's just the knee, the best thing, and I can tell you personally, because I do have some hyperextensible joints as well, is actually finding a good physical therapist. And one of these conferences, I had a poster right next to a benign joint hypermobility expert who was a physical therapist. And she was telling me how important it is to find a good PT. I love physical therapists. I feel like we really need to work more together, and we're really trying to at our Hopkins Myositis Center. But they have specific exercises when your joints are that hyperextensible so that, you can actually build the muscles so that you're not extending your joints a lot. And also yoga is a big no-no. Anything you're going to extenuate those hyperextensible joints in people who have joint mobility disorder. Yeah.
Okay, so it sounds like hyperextension isn't a symptom of myositis.
That is
It's
correct. That is
right.
correct.
Yeah. Okay. Um, is there a specific diet plan or vitamin supplements that help slow the progression of muscle degradation in IBM patients?
That's a really good question. I feel like there's a lot of research coming out about, mitochondrial dysfunction in patients in myositis, but more so in patients with inclusion body myositis. So there is a lot of interest in trying to like pick a good mitochondrial cocktail, so to speak, which I'm not an expert on, obviously, but I think there is a lot of interest in that. Otherwise, we always recommend there's some evidence, limited evidence that coenzyme Q10 can be very helpful for the muscles, at least 200 milligrams per day for patients with inclusion body myositis. And then bottom line is to improve the mitochondrial dysfunction that we see in patients. And mitochondria is, sorry, I should have mentioned that, is the kind of the powerhouse that produces all the energy for our muscles and all of our organs, but in particular in the muscles because it's a very vascular organ. And so the coenzyme Q10 can be very helpful. And then some type of cocktail has been thought about in the research setting, but I don't think it's very well delineated at this time. Yeah.
What is an appropriate dosage of prednisone? Do some people, this is like
Mhm.
they put three questions into one.
Oh, okay.
So they want to know the appropriate dosage of prednisone. Do some people go to Johns Hopkins as well as their local doctor? And what are the advanced stages of myositis like? So you can go through and I'll remind you.
Yeah. Well, I'm sorry, what was the first question again?
I know, right? What is an appropriate dosage of prednisone?
Ah, okay. Well, this I can go on and on, I guess, depending on what type of myositis you have. So inclusion body myositis, we don't think steroids really help at all. And high dose steroids can cause steroid myopathy, which means, the steroids in and of itself can cause severe muscle weakness. So we really try to avoid high doses unless you really need it. And the key kind of parameter to determine what dose you need is really dependent on the severity of your organ manifestations. Okay, we said in IBM, the steroids really don't work anyway, so let's take off IBM off. Let's talk
Mm-hmm.
about dermatomyositis. So in dermatomyositis, steroid dose, so I've learned a lot from my dermatology colleagues. If you only have skin predominant dermatomyositis, I would have to say a lot of the experts in the field are not even using high dose steroids unless it's absolutely necessary because some of our drugs work really fast. And why expose our patients with skin predominant dermatomyositis to high doses of steroids when we know prednisone, some of my colleagues call prednisone is poison? Because long term, when you use it, it's really hard to get off of it. We know it works, but all the side effects we really don't like. But if it's beyond just skin predominant dermatomyositis, and obviously if you have skin ulcers and like, it's severe skin involvement, then of course we really need to use steroids. But if it's not that severe skin, a lot of my derm colleagues are not even using really steroids. So maybe use steroid ointments, but wait for the steroid sparing agents to kick in right away. If you have muscle involvement, though, for dermatos, skin and muscle, it is important to use steroids because we don't want the muscle inflammation to actually cause long-term damage and fatty replacement. So that is really dependent. So if you have skin and muscle involvement, that is really dependent. The dose is dependent on how weak you are and how high your muscle enzymes are. That kind of whole picture that your rheumatologist is making a decision on. Now, if you have lung involvement, and also muscle and even heart involvement, then we tend to be a little bit more aggressive, especially with the heart and the lung, where we will use much higher doses of steroids, as long as it's not contraindicated. Like, for example, with overlap myositis with scleroderma, high dose steroids is completely contraindicated. So we would not want to use really high doses in that case. For necrotizing, we still do use steroids. If you're very weak, we do think it helps with improvement of muscle strength and lowering the CK. But some of my neurology colleagues will not use high dose steroids. They will just go immediately to IVIG. And so there is a paper that had come out in the past couple of years saying no steroids, but just using IVIG and steroid sparing agent first line, especially in H and GCR necrotizing myopathy. So, but that is not a consensus kind of guideline statement, or there's just one paper on that. It's not completely evidence-based. We want to have more studies on that. So we still use, steroids for necrotizing myositis. I think those are the main ones. So, okay, that was steroids. For Hopkins Myositis Center, we do routinely recommend, because we have over 50, we've looked at our patients list, and over like 50 to 60% of our patients are out of state. And we really want to be the best rheumatologist for our patients. But when patients live far away and we can't see them right away, look at their skin, examine their muscles, and, have a really good conversation. Is this really a flare? Does this constitute a flare? And things have to be done in person. So we do recommend having a local person if you're not local to our Hopkins Myositis Center, to work in concert with a local rheumatologist as a team. I think that's really important. And I feel like 99% of the time, the local rheumatologist is very, very open to that and want to help. Yeah. I forgot the last question.
What are the advanced stages of myositis like?
I would say the advanced stages, so it depends on which organ we're talking about. So since they were not specific, I'll just talk about the muscles. So if the muscles are in advanced stages and the treatment didn't work, you can get muscle will try to, I always say repair itself. And we have these important cells in the muscles that will try to repair the muscle over and over and over again. But if you don't give it the right treatment, then the muscle can't repair itself any longer, and the muscle will turn into fat. Just like the flab around my waist, it will turn into complete fat. When that happens, it's almost like a patient with muscular dystrophy where it's irreversible damage. So once the muscle turns into fat, then we don't currently have any kind of treatment to reverse that. And so that is always our goal, especially, and this tends to happen really quickly in our necrotizing myopathy patients, specifically SRP and HMGCR autoantibodies associated ones. In fact, even within the first 3 years, this can happen. And so we actually have a clinical trial that's going to be starting very soon. That's NIH funded, especially for our necrotizing patients. That's going to be starting soon because we want to try to give these drugs that we think work pretty well early in the disease, like within the first year of disease, not waiting 3 years, whatever, 5 years sometimes, which is ridiculous, but treating it aggressively upfront, so to avoid any fatty replacement and irreversible damage in the muscle. That was a special plug-in for my upcoming trial. Sorry.
Well, you can talk about trials. They wanted to, another question said, what clinical trials are going on at your center?
Oh, yes. So we have many. A lot of them are fully enrolled. So for dermatomyositis, we have an ongoing trial. We have several. We have an ongoing trial of a JAK-TYK inhibitor, which blocks this interferon pathway. It's an oral drug, and it's called the VALOR trial, VALOR trial. And that's when I say registrational study, that means the FDA was involved from the beginning. And if this is a positive study, it will become FDA approved. So they enrolled, I think, almost 220 patients globally, including at our site. And the results should be out hopefully by the fall. And so I think that is one drug that in the dermatomyositis, it's exclusively dermatomyositis, is looking we're very excited about it. We want to know what the results are. Because right now, there's only one FDA-approved drug for dermatomyositis, which is IVIG. So if this gets FDA approved, this will be another drug potentially that can be used that's oral. There's so many, but I'll just talk about the ones that I'm really excited about at this moment in time. There's another drug that just released some results at our European EULAR, which is a European rheumatology conference. That was in Spain about 2.5 weeks ago, I think. And that is also showing promising results. It's primarily, they included all patients, but you had to have a positive antibody. They included necrotizing myositis, dermatomyositis, so none of these trials are inclusion body myositis specific, but I'll talk about a couple that are, especially one that is hopefully exciting to come up in terms of results in the future for IBM as well. But that one is efgartigimod, and the company's argenx, and it's a sub-Q injection, and we also have enrolled a patient in that trial. That is fully enrolled as well, multi-center international global trial. And I think it has some promising initial results. And so I think in the phase 2, and that's why from the phase 2, they decided to move into phase 3. And that's a sub-Q injection, but it's already FDA approved, this drug, for myasthenia gravis, a neuromuscular condition, and also had really good results for CIDP, which is a chronic demyelinating disorder where you get autoimmune nerve dysfunction and you can't feel sensation in your legs, and they use IVIG a lot. So the thought is for that drug, instead of blocking the interferon pathway, it's similar like IVIG. It's getting rid of the antibodies we think that are contributing to the disease process. So that one is another one that's very exciting. I think that those two are the most kind of in line to see results, hopefully. And another one that we're involved in, we're in the contract phases right now, but it's actually directly blocking interferon for dermatomyositis. And that is definitely, since you're blocking it directly, which we think is the most important pathway in dermatomyositis, that is already FDA-approved drug for lupus. And so I think that is also promising. So I know I can go on and on, I guess, but I won't. And then, of course, we have another trial coming up, the NIH-funded trial from NIAID, where I'm the PI on. And actually, I did receive a letter of support from the TMA when I submitted this grant. So I'm very grateful to that, to the TMA. But this is actually so I am the PI on the trial and the chair of the protocol. And this is through the Autoimmunity Centers of Excellence, which has been around in the NIH since the 1970s. And this is the first time our Hopkins group is joining this Autoimmunity Centers of Excellence. It's the Centers of Excellence composed of, multiple sites like Harvard, MGH, Emory, and, UCLA, and all these sites. So it's going to be a multi-center but small trial that is going to be using a third-generation B-cell depleting agent like rituximab, but stronger, ublituximab. And the company has been very generous, is going to be giving free drug to us. And it's going to be a multi-center trial, and we're the lead site. But we have some commitments already, but I can't tell you all the details because we're not live yet. But from major myositis centers throughout the country. It's going to be a small study, but I hope to talk about it in more detail. I think we'll have more details at the patient
conference.
Yeah.
Great. Speaking of research, what is the most recent research on mitochondria and IBM? And is there any new research on that to suggest a possible treatment?
Yes. So I would say the person who's published a lot, and I think he's on our medical advisory board, I think, is Ellie Nadoff. He's doing
Uh-huh.
a lot of IBM research on mitochondria um, in the lab. And so I think his last name is Naddaf. So he's published on some of that in muscle biopsies as well. Um, I don't know if my colleague Maima Albeda has also published in it, but I know she had some data in it. But I think please stay tuned because I know she is having some exciting data coming out. But I'm not going to talk about it. It's not published yet. So I think though he would be the best person if you look. He's at Mayo Clinic, who's doing a lot of research in that area for mitochondria. And my colleague Lisa Christopher Stein, who is the founder and director of our center, has some ongoing studies looking at, metabolomics is what we say when we're looking at all the components of metabolism in the muscle. But it's not ready for prime time yet. So I think you're going to hear more about it. But I think some of the already published data is from Ellie. Yeah.
This person has two issues driving them crazy. Itchy scalp, itchy pimples on face, and also a lot of muscle pain at RH biceps. Do you have any recommendations for relief?
Muscle pain and
It says RH biceps, and I'm not sure what the RH stands for.
yeah.
But I guess it's just muscle pain. So.
Yeah. So I have to share one of my experiences. And this patient was on steroids for a long time. So I don't know if that's the condition, but I think it's important for all of us to be aware of. Like sometimes when you're on steroids for a long time, there's some reports that there's associations like tendon rupture and things like this. So if there's a lot of pain in that isolated muscle, it's only on one side, I would be a little bit wondering if that's really from the myositis. And I think doing some imaging like an MRI to look at the shoulder and where the bicep tendon inserts and making sure the tendon's okay, there's no tears. And that's why it's kind of, referred pain from the shoulder into the biceps. I think that would be important to ascertain. But for muscle pain, for myositis in general, we think is sometimes from like fasciitis, especially in dermatomyositis. So that's the layer over the muscle, the thin layer over the muscle, the fascia. There are a lot of nerve fibers in there, and we're still trying to learn more about it. But we do see that when that is inflamed, and you can see that on MRI or even if you did a muscle ultrasound, where the MRI is nice because then you're seeing the entire muscle and you can see exactly where it's lighting up. And if that's the problem, where that's where a lot of pain is, then sometimes we do increase immunosuppression um, as because we're trying to treat the myositis and myofasciitis at the same time to see if that helps with immunosuppression, like any of your immunosuppressant medications. But make sure there's no focal reason for it to, be so painful. Yeah.
Can muscle damage show up on an MRI? Can it be masked if still on prednisone?
No. So muscle damage on MRI. So the muscle MRI, the one we order is the T2 stir. And that's a short tau inversion recovery technique. And you always want to get that one to look for your muscles. And so the key sequences we look is the T2 stir, which is just a long name for, short tau inversion, the stir, short tau inversion recovery, and T2. So on that sequence, we can see if there's disease activity and it lights up like, bright lights around in the muscle, around the muscle. That means there's a fluid signal indicating there's potentially inflammation. But it doesn't diagnose myositis because if a log fell on your leg and you didn't get any blood flow, then that would also light up because there's inflamed tissue because you didn't get any blood flow. So it's important to put the clinical context into it. An MRI in of itself cannot diagnose myositis, right? And then for damage, we look at T1. So the T1 is a sequence that's always embedded in all my, MRIs. And that tells us if there's actually damage, because when we bring it up, you can see fatty replacement in the muscle. And it doesn't matter if you're on steroids, doesn't matter if you're on methotrexate, doesn't matter if you're on IVIG, rituximab, Cellcept, Imuran, anything, or CAR T, any type of clinical trial, it will not mask it. If there's damage, you can see it. It'll be white. Yeah.
This person's grandmother died of myositis and vasculitis, and autoimmune disease runs deep in their family. Would you recommend genetic testing? And if so, which panel?
Yeah, so there's no genetic testing per se for autoimmune diseases. Um, what we always tell our patients is if your mom had like an autoimmune disease, then it's possible that you will get the same disease, but a different autoimmune disease. I don't think we're there yet that there's a specific genetic like test to look for autoimmune disease. Um, so we're not there yet. But there are specific, associations that are reported in the literature. And some labs can test it, but we don't routinely check those because the clinical presentation is going to be the most important. Now, I do tell my patients, like, if someone is developing Raynaud's, you know, before the age of 35, and it's not I'm sorry, after the age of 35, because before the age of 35, usually it's, primary Raynaud's. And Raynaud's is when like you're exposed to cold or, stress, your fingertips turn white and things like this. That the published literature in Raynaud's is if you develop that after the age of 30, 35, it's probably a connective tissue disease, right? So if your child is developing Raynaud's late in life, then it's something they really should see their primary care provider and get an ANA test. They should look at their capillaries with a dermatoscope and make sure it's not abnormal, and give that family history to make sure nothing is missed. Yeah. But in
It,
terms of other things, if someone has a like rash that develops, knowing that background of autoimmunity will help the dermatologist or rheumatologist think, oh, maybe this is an autoimmune skin condition, and not just be like, oh, it's probably just, contact dermatitis. Yeah.
if my creatine levels in blood work continues to drop, does that mean I'm flaring? If not, what can be done to help increase creatine?
If the creatine level in the blood,
Yeah, it doesn't have an E at the end. Creatine levels and blood work continues to drop. So I think she's talking about CK. Does the level of dropping mean that they're flaring?
okay. So, hmm. So this if it's the creatine kinase, which is a CK, like Rachel was saying, when it drops, let's say you presented with really high CK levels. So let's take a step back. If someone has necrotizing myositis, usually the CK is very high at initial presentation. If someone has dermatomyositis, routinely the CK is not very high. And we know this. All the myositis experts know this. In fact, the CK can be 200 and a patient can be very weak. And you look at the MRI, it's going to light up. So in dermatomyositis specifically, I do not use the CK level as a barometer of your disease activity. It's really your presentation, and maybe the muscle MRI can also help, because if it lights up, and we know there's muscle inflammation. So let's take the example of necrotizing myositis. If the CK is high and it came down, usually that correlates with disease improvement. Now, there is a scenario when the CK could be going down, but you're getting weaker. So when would that be the case? So for necrotizing, it would be if the disease has kind of burnt out and you have a lot of damage in your muscle. So the muscle has already turned to fat. And there's no more muscle to be inflamed anymore because there's already damage there. And so we kind of call it, for all kind of poor man's way of describing it, that the muscle has burnt out, and that's why you have atrophy of the muscle, and the CK is not going to be that high. And that also, we think potentially is happening in inclusion body myositis, because if you see early IBM, our patient's CK is, I've seen as high as like 1,000, 2,000. But then over time, if you follow them 10, 15, 20 years out, the CK is probably not that high because there's been damage already. So I don't know if that's the question. Now, creatinine is also a marker of muscle bulk. So, if you have a lot of atrophy, and creatinine is the one that we, look at for kidney function, right? So if that is really low, that could also be indication you have muscle atrophy. Yeah. And if it's getting less, it could mean that your muscles are atrophying further for whatever reason, if you have IBM or you have necrotizing myopathy and the disease is kind of advanced.
This person has a similar question about CK levels. They have polymyositis, 27-year-old male, diagnosed 10 years ago. If my CK levels are stable for years now at 7,000, does that mean I am stabilized?
That's a really high CK. That's a really high CK to be stable. Um, I would have to understand the kind of clinical context for that. For us,
Right.
yeah, whenever I hear the diagnosis polymyositis, I hope your doctor has ordered the myositis panel. In fact, I have to say, young people, if he's really young, like is he 28 now?
He's 27 now and was
Yeah.
diagnosed at 17 with
Yeah. So I have a patient
polymyositis.
who actually was misdiagnosed as having a muscular dystrophy. And she Googled it and was like, told her doctor, you need to order my myositis panel because her biopsy looked like she had muscular dystrophy a little bit. And it just kept getting perpetuated, the diagnosis, right? Once it goes in your medical, you have to be very careful sometimes. And so finally, the doctor ordered the myositis panel and it was SRP positive. And so she had a treatable disease, but for a year and a half, they thought she had muscular dystrophy. So I would think about this in your case too. Like, how did this polymyositis diagnosis come about? Did they do because polymyositis is really a diagnosis of exclusion. It really is. Because if there's no myositis autoantibody, you need to have a muscle biopsy to figure out why it's polymyositis. I would not just put you in that category without doing a muscle biopsy and having a myositis panel checked. And if those myositis panel is negative and the muscle biopsy is showing true polymyositis, then I would really get a neuromuscular specialist involved to see if you actually have a genetic muscle disorder, you know? So I hope, because 7,000 is not normal, you know. Um, the treatments we provide for myositis should lower your, CK level to when it resets in our necrotizing myopathy or PM patients. Usually we expect it to go down. I've seen stability at like 500 to 1,000 is really our goal, or even get it to normal as much as possible. Sometimes our patients with CK coming in at 15,000 may not ever normalize, but they would get stronger, right? Like full strength, but their CK is in the 500 to 1,000 range, and we're okay with that. And we would supplement with a muscle MRI to really assess, is there still ongoing disease activity that I need to, be more aggressive about treating? So I would ascertain if that, a little more information, yeah, for that diagnosis,
Good.
especially because
Can you
yeah.
explain steroid-induced myopathy?
Yes. So what we know about steroid-induced myopathy is that usually in the first kind of 4 to 6 weeks of starting a high dose steroids, like usually it's about, if you're really tiny, it's usually based on weight, right? How we dose it when we give high dose. So it's usually 1 milligram per kilogram is really high dose. So if let's say you got 60 milligrams of prennazone, and that's a pretty high dose for someone who's like 40, kilograms or 50 kilograms. Then within a few weeks to 4 to 6 weeks max, um, you get extremely weak. I am very tired. I've had this happen in my career since I've been here at Hopkins for 15 years once in a patient. Actually, she didn't have myositis, but she had vasculitis. And we were treating her with high dose steroids because it was affecting her brain. And so we had to give her really high doses. And I remember she was like having severe, like her neck was getting weak. She couldn't really lift her arms at all because she was so weak. And it was really looked like, myositis, but she didn't even have myositis. So it was easier to detect that this was going on, that it was a steroid myopathy. But as
Hmm.
soon as we lowered the pred, right? So when that happened, when I knew that was happening, to lower it really quickly, but safely. And it resolves. So once you withdraw the steroids, it will get better. Yeah. So those are kind of the symptoms. Yeah.
Okay, let's see. We have time for a couple more questions. What non-surgical options are available for treatment of calcinosis?
That's such a hard topic. I laugh because that's like I think on all of our minds. Like I really wish that I can find some type of treatment for that. That's like something I really hope to we can get some answers to. It's tough. It's very tough. Um, so let me tell you about some of the work that has been led by Dr. At the NIH by Adam. Why am I blanking on his last name?
Schiffenbauer.
Schifferbauer. So he
Yeah.
has a lot of interest in imaging and calcinosis. And so he did a trial that I don't know if the results are published yet with sodium thiosulfate infusions. And where does this drug come from, sodium thiosulfate? So that came from actually learning from our nephrology colleague, our kidney colleagues, because patients who are on dialysis, they get um, miss kind of the calcium metabolism is not very good when the kidneys are not working. And they can also get painful calcium deposits on their legs. So I've had this happen in my patient who actually had myositis and also had renal failure and was on dialysis. And that happened to her. And I remember we instituted sodium thiosulfate immediately, and all those calcium deposits disappeared. Now, mind you, this is not a patient with dermatomyositis, but a patient with renal failure, and that's why it works that quickly, right? I mean, it was amazing because those lesions disappear completely after several infusions. So kidney specialists actually have a protocol giving doses of sodium thiosulfate for this specific reason in dialysis patients. So that was extrapolated to patients with calcinosis and dermatomyositis. And they've used it in trial settings. And I think there's been some stabilization of old ones and prevention of new ones coming about. And I have had one patient, somehow she got it approved through her other doctors locally, who was using it for, calcinosis for her dermatomyositis. And it was kind of the similar story. Like nothing new started, but anything old didn't get bigger, basically. So the key, I think, is really to try to, but it's not ready for prime time, right? And it was a small study. It's not a phase 3 registrational study. So I think we still don't know if sodium thiosulfate works, but it can potentially work. Now, I've definitely had dermatologists inject it under my patient's skin, but it's extremely painful when they inject that sodium thiosulfate product into your skin. Very, very painful, so I wouldn't recommend it. I mean, you could try it if you have like really high pain tolerance, but I don't know that it's that effective. I think the infusions are better if you can get it. Recently, some of the work that we've also done in a JAK inhibitor study that was published in 2020, but this trial was done from 2017 to 2020 of dermatomyositis patients. We gave a JAK inhibitor, a pan-JAK inhibitor, tofacitinib, which right now is FDA approved for rheumatoid arthritis, psoriatic arthritis, juvenile arthritis, or Xeljanz, that's what it's called if you see commercials. So we also saw that the calcinosis actually decreased in some of our patients in the trial, and we published that. So you can look me up in PubMed if you want to read about that case series. And if you actually look in the literature, there was reports that it also helped reduce calcinosis in juvenile dermatomyositis and also in other small reports. And so there is some thought that it is doing some remodeling in the bone microenvironment, that pathway, and potentially any of these drugs that block interferon may potentially, result in this. But I think TOFA in particular blocks a specific pathway that we see with bone remodeling. And so that might be a reason it works. But I can tell you right now, it doesn't work fast. It takes months and months to see the response. And the same thing, when I have my patients on it, they're seeing that there are no new spots. but any of the old spots is not getting bigger. But in the trial, some people who had old spots felt like it was getting smaller. So I think we still need a lot more data. As long as there's no contraindications, I have been ordering it more frequently. If I have someone just coming in for calcinosis, if I could get it approved, it's very hard. And so I've been talking to the company that's doing this phase 3 trial that I told you about, the Valor trial, that, they are collecting the data if somebody has calcinosis in this 225 patients. So hopefully we can get some of that data after the trial is done to see if any of these patients also had improvement in their calcinosis. And then if this drug is FDA approved, maybe we could even use it for calcinosis, for dermatomyositis.
All right, well, that is all the time that we have. We are still closing with 40 questions. I'm so sorry we cannot get to all of them, but that is why we do this every month. So if you didn't get your questions answered, please visit our YouTube channel because we have lots of Ask the Experts on there as well. And we will do our best to use any unanswered questions in future programming as well. And thank you, Dr. Peck, so much for taking the time to do this. We really appreciate your work in the community as a whole. And so I've got a couple of things to share with you that are coming up. Join us tonight. Come back later. We have a special presentation for those of you with IBM. We are It's going to be hosted by TMA Men Managing Myositis Affinity Group, but it is open to the entire community. So thank you to Eric Rochelo for arranging that. It is about the IBM disease registry at Yale. This houses one of the world's largest systematic categorizations of IBM, its origins, biological markers, its risk profile, its natural history, and its clinical management. It's open to everybody, so please come back. It's at 7 p.m. Eastern. You can register on our website, or it may be inside the chat. And then also we've got our next new member orientation is July 11th at noon. And look how many O's I put in that. I was doing that in a hurry. Noon. But yeah, it doesn't matter how long you've been a member. We would love to see you. It's great information. It's meeting style. You get to meet all of the staff and our board chair. And then afterwards, we do breakout rooms by diagnosis. So we hope to see you there. And then also my last plug is for our regional support and affinity groups. And that link should be in chat as well. So again, thank you everybody and enjoy the rest of your day. We hope to see you tonight at 7.